The products, Residuline is the newest one there. The old Selegiline has been around for years and years and years and is more related to the amphetamines and does have somewhat of a stimulant effect. You can't take it beyond noon or you might find you're going to have some sleepiness occurring there. So small effects can be used in early stage disease, and often we'll start on this one, but some people will add it to levodopa, carbidopa as the disease progresses in order to extend the response to levodopa, carbidopa. And as I said, some suggestion that Residuline may actually reduce some of the freezing independent of levodopa. It's interesting work that's being done, so maybe we'll see something from that. Headaches, increased side effects related to levodopa can be seen because basically what you're doing is increase dopamine in the brain above what levodopa normally does. So again, watch for changes in blood pressure as well and sudden falls. Dry mouth, headaches, dizziness, these are all related to the dopamine effect. Dopamine agonists are quite interesting because what they do is they directly attach to the dopaminergic binding site, so they act like dopamine, and they increase the response and increase mobility. These medications are used early on in early onset disease and add-on therapy in late onset disease as well, or when levodopa has already been established. Anything that we can give to delay the onset of using levodopa may reduce the incidence of dyskinesia. So you often see these medications used as first-line therapy. Not all physicians are happy with these types of medications. As I said, you can get more problems we get related, nausea, vomiting, significant amount of postural hypotension, confusion, hallucinations, vivid dreams, fatigue. But what I find is impulse control disorders. I've had people in nursing homes that are compulsive masturbators. We have compulsive shopping and compulsive gambling, or we have excessive daytime sleepiness and sleep attacks occurring from these medications. What's happened in certain areas is the physicians, because of medical legal aspects, are somewhat refusing or discontinuing patients on these medications. As I say, inappropriately discontinue, because if you start on and you're not having a problem, why stop it? As long as we're monitoring for those potential problems that we could see. So the drugs are used well. If they're initiated, we initiate them slowly. If you stop them slowly as well. Drug interactions, anything that will increase the levels of dopamine, but we worry about some medications like smoking and ciprofloxacin, and I call cigarette smoking or nicotine a medication, will increase levels of these medications and potentially can cause problems as well. They're administered less often, usually started on daily, but 2 to 3 times, not 8 times a day. The COMT inhibitors extend the life of levodopa, have to be administered at the same time as the levodopa in order to do that. There's the fixed combinations that we're using as well. They can be administered up to 8 times a day. Literally, they increase the problems of levodopa or dopamine, so you're going to get more postural changes, but more hallucinations. A little bit of orange-colored urine can occur. These are good medications. Be careful when you're using them with other dopaminergic agents. And I look at a sick day policy on these medications. So if you get really sick and you're on COMT10, hold your COMT10. Take your levodopa. When you feel better, add your COMT10 back in, and you might find you do better. You might, just to avoid having those dyskinesias. Anticholinergics, younger patients are fine, primarily tremor. Okay, that's we use it. In older patients, you lose your mind, you dry out, you have problems peeing, and oftentimes dizziness and falls associated with them. They're not good medications in older patients. The anticholinergics that you commonly see are the ones listed here, trihexyphenidyl, procyclidine, and some people may still be on them. I see them coming into nursing homes, and I try to reduce those medications wherever possible. Families are saying, no, don't stop my medication, but the person's having other problems, that these are the first ones to go. Interesting, we try in general to reduce what we call cholinergic load in elderly patients. And all our bladder medications, all our GI medications or stomach medications all have anticholinergic side effects because they slow things down. So that's what we worry about. So they are helpful for tremor. They can be used as adjunctive therapy, but not as we get older. Amantadine, as I say, I dislike it. We see a number of patients on it in order to reduce the dyskinesias associated with levodopa, carbidopa. The problem is they're cleared by the kidney, and if you have a bladder infection and you dehydrate, the medication can cause extreme delirium, mood changes, and we have a lot of psychoses happening, and as I said, I've had deaths associated with this medication. So inappropriate dosing, we no longer use it in long-term care as far as prophylaxis or treatment of influenza because it doesn't work. I dread the day if we have to go back to this one. It is an anticholinergic, and it does have effects to directly increase dopamine levels in the brain, so it has a dual effect there. What are we looking at when we're looking at non-motor symptoms? Constipation is a problem, and we tend to add stool softeners. People may need laxatives as well just to keep the bowels going because we don't have bowel problems. Autonomic discomfort is usually excessive sweating, drooling, things like that. Clonidine is a product we've been using. It can use, there was a question earlier for night sweats and that. Clonidine might work as well. The problem with Clonidine is postural instability and falls. Orthostatic hypotension is usually maintaining your blood pressure and your salt levels, so there's medications we use there. Bladder dysfunction medications are all anticholinergics, and they may help with tremor and your bladder function, but you end up with problems. Erectile dysfunction, everybody knows Viagra does still work. Botox and some of the anticholinergics will work for drooling and that. We tend to use atropine eye drops orally. It, again, can cause some confusion. Dysphagia, we crush, chew pills, and give it by G-tubes. We do what we can in order to keep medication on them. Domperidone, a lot of people are on. It's used to help block the peripheral side effects of dopamine, which is the nausea and vomiting. It helps to improve motility, and it actually works quite well. There's some new literature that suggests we should not exceed 30 milligrams a day, and most of my patients are on 80 milligrams a day. The Health Canada recommendation came out because of irregular heart rate that could potentially cause death. Because we're blocking an existing situation and patients have done well on it, I have not reduced dose on any of my patients at this time. I'm hesitant on going to higher doses like the 80 milligrams on new patients, but it's still being used by Parkinson's doctors in order to treat nausea and vomiting. Depression, we do use certain agents that are commonly used. Effects are the SSRIs like escitalopram or Cipralex. Sleep disturbance, we already heard clonazepam works well. I keep clonazepam on the back bench. I like the product when it goes to a benzodiazepine. I dislike the other agents because they don't work, and that's our Ativans and everything like that. Trazodone might be beneficial for sleep disorder. Zopiclone is not available in Canada. That's the Lunesta that Dr. Rowley talked about. It's something that we could potentially add in. It's relatively safe. The Zopiclone available in Canada is much more addictive, very hard to come off of as far as sleep disorder, and that's the blue tablet that leaves us feeling really tinny and bitter taste. Dementia, we still use Exelon, Aricept for our Lewy body dementias that are happening there. And I actually touched on this already, that I think pharmacists have to be involved in your therapy, and I think most of you rely on your pharmacist for what's going on. So please use us, and that's it. I tried to get through all that.
You certainly made the most of the last few minutes, Rick. On behalf of everyone here, a very, very small token of our appreciation. I know that medication is something that I hear about all the time, and I get a lot of questions about. So having your expertise and being able to share in detail, I'm sure a lot of people are walking away understanding what their medication does and the function of it much better than they did before. So very, very small token of our appreciation, and thank you again.